All good? Okay, so hi everyone, my name's Anthea and today I'll be going through respiratory with you guys. We've got a bit to cover, so if you have any questions, please feel free to email me, or I'm happy to answer any questions at the end. And if we don't get time to cover them, I'm happy to also answer them and get those answers to you. I've also got some MCQs throughout, so if you guys want to answer them, maybe privately message me so everyone can have a chance, and then we can go through them. Perfect, we'll get started. Just get rid of my... Okay, so today we're going to be covering quite a bit. So your R1 conditions, your R2, and also some lung pathology and OSCE tips as well. Oh gosh. Oh. Sorry about that. We'll go through first question. So a previously well 18-year-old female complains to a general practitioner of increasing difficulty in breathing shortly after starting jogging in the morning. This has been present for 5 weeks after she had a bout of flu. Clinical examination was unremarkable. So if you want to send me through your question. Sorry about that. I keep clicking. I can't find the chat box. Oh, there we go. Yep. Perfect. So the answer is B. So this is asthma. So we're going to go over asthma first. Sorry about me clicking the answers. So first of all, asthma is a reversible obstructive small airway disease. And we know that it occurs in 1 in 10 Australians. In terms of knowing the pathophysiology, it comes back down to the fact that there's narrowing of the bronchi, and that's due to bronchial hyperresponsiveness, bronchospasm, as well as inflammation, hypertrophy of the smooth muscle, and increased mucus production and edema. And as you can imagine, that all leads to narrowing of the airway and therefore an airway airflow obstruction. We know that allergic asthma, although occurs due to a type 1 hypersensitivity reaction, so that's your IgE mediated response and your mast cell degranulation. So in terms of triggers, there's this nice mnemonic A, B, C, D, E, F, G, and that stands for your allergens, so your dust mites, your pollen, and as well as occupational dusts. Your airway pollutants, so your smoking is a very big risk factor. Your beta blockers as well, as you can imagine, that causes bronchoconstriction. Cold air can also trigger it. Drugs, NSAIDs because of increased leukotrienes, and then your exercise, flu, as was in the case, and GORD. So here I've also broken it down in terms of allergic and non-allergic risk factors, but you can use the mnemonic. But one thing to note is that when you are doing your histories, it's important to not to forget to ask about eczema, hay fever, so your atopic triad. And as we saw in the exam question, viral infections or preceding flu is very common risk factor. So in terms of clinical features, it presents with your clinical tetrad, I guess you could say, of cough, wheeze, chest tightness, and shortness of breath. But it's really important to also ascertain, are these symptoms getting worse at night and early in the morning and during activity? Because we know that's quite common with asthma. And then again, asking your atopic triad and your vaccinations as well. In terms of examinations on vital signs, they tend to be tachypneic, tachycardic. They can get what's known as pulsus paradoxus. So that's more than 12 millimercury fall in the systolic blood pressure during inspiration. And then also looking out for signs like eczema and also allergic rhinitis, such as your nasal polyps and swollen mucosa and discharge. In terms of when you're inspecting the chest, you want to look for the accessory muscle use because of the increased work of breathing. They might be hyperinflated, and then also Harrison sulcus. And then in terms of auscultation, they're going to have softer breath sounds. A polyphonic wheeze is a typical buzzword, I guess, on exams. And the silent chest, we need to be aware of the silent chest. That's quite severe. Okay, so in terms of working it up, so you've done your history, you've done your exam. So now in how we're going to diagnose it. So to diagnose it, you need to do spirometry, pre and post bronchodilatory test. So we know that when we do that, we get the FEV1 to FEVC ratio less than 70%, and that's our obstructive picture. Post bronchodilator, we were looking for a more than 12% and 200 mil change in the FEV1 or FEVC. And what that indicates is a positive bronchodilator response. It indicates that there's reversibility because we know that asthma is a reversible obstructive airway disease. You can also look at the flow volume loops. And I've got a picture on the next page. And this was something that came up in our practice OSCEs during the year when we were doing them last year. They gave us a loop, a flow volume loop, and you had to sort of pick up that it had a concave deviation of the expiratory phase of the flow volume loop. I might just go on the next page and show you that. So that's here. And that's because of the obstruction, they can't expire as much air out. But, in terms of other tests, these are sort of more for monitoring or when they're stable. You can also do a bronchoprovocation test. So that's just test for airway hyper responsiveness. And they usually do that like with mannitol or histamines. You can do a DCLO. It's not a gas exchange problem, so it's going to be normal. And you can do allergen testing, particularly if it's an allergic asthma. And then for exacerbations, you can do FBEs, ABG. You will get a VQ mismatch. And also peak flows for monitoring, and you can do a chest x-ray, but you wouldn't really find much unless it was superimposed with, say, an infection. So that was just the spirometry and flow volume loops for your reference. Now, in terms of acute management, there's sort of two ways of thinking about it, what we can do in the community. So in the community, as many of you are aware of, we do the 4x4x4. So this is where we tell them first cycle, you do 4 puffs, and you do 4 breaths per puff, and then you wait 4 minutes. Then you do a second cycle. Now, if after 2 cycles there is no improvement, you need to repeat the 3rd cycle and call the ambulance. And then keep repeating cycles until the ambulance arrive. But in terms of, as soon as they, I guess, come to hospital, if we're talking about an ED situation, you then need to assess the severity of the asthma. And this is more of a pediatric approach, but I find it's very easy to remember and sort of applicable to any sort of acute asthma situation. So it's called MUMUS, and it's mental state, oxygen, worker breathing, and speech. So you assess their mental state. So mild severity would be from normal, going all the way to severe, where they're agitated and distressed, to life-threatening, where they've lost consciousness and drowsy. Oxygen stats going from 94% to then 90%, and then 90 to 94%, and then less than 90%. And then worker breathing, this is where they're kind of normal, and then we're getting the increased use of accessory muscle use, and then eventually a silent chest. And then the speech is going from sentences to short sentences to words to absent. So you can see the progression. So in ED, as soon as they come into ED, you need to always do your doctor's ABCD. You assess the severity using the MUMUS, which we just went over. And then you need to just go through, do they need oxygen? So is it less than 92%? We want to titrate it to 93 to 95% for adults. And then you start your inhaled bronchodilators. So it can be salbutamol. They recommend 12 puffs with a PMDI and spacer, and you can add ipratropium as well. So you do both at the same time. Or you can do it via nebules. But in saying that, people have this preconception that doing nebules is better because it's nebulized. But in doing it through a PMDI and spacer is just as effective. It's more that if they can't use a PMDI or a spacer, then you'd go to the nebules. And we do this as a burst therapy. So that means you repeat it every 20 minutes for the first hour. You can then add on prednisolone, and that has to be within the first hour presentation. And then you escalate to mag sulfate, aminophylline, IV salbutamol, adrenaline, and then non-invasive positive pressure ventilation. And during this time, you'd be considering admission and escalating to ICU if they're deteriorating. On discharge, you always have to do an asthma action plan. They might have to continue their prednisolone. You might start them on a preventer, so inhaled corticosteroid, and then arrange with GP follow-up. So if they have now chronic asthma, you always have to go through your non-pharm things and your pharmacological things. So you would educate them on asthma and how to use their inhaler correctly with the spacer, avoid triggers. So if pollen is a trigger for them, so maybe checking the pollen counts for that season. SNAP-W is always really good just to add in. And then vaccinations, you recommend the flu vax and pneumococcal. And then always do an asthma action plan, and then they can monitor at home with a peak flow. And this is just a reminder that when we had OSCEs, we were told to know the asthma action plan. I don't know how much that would work for you guys this year via Zoom, but do definitely know how to explain a PMDI and a spacer as well. In terms of pharmacological, we start off with the short-acting beta agonist, so your salbutamol or terbutaline, and the ADRs for that is that they can get a tremor as well as tachycardia. then we add then you can add a preventer, so your inhaled corticosteroids like fluticasone, and the ADR for that is that it can cause oral thrush, so encourage them to regularly wash their mouth. And then you can add a symptom reliever, your long-acting beta agonist, which is salmeterol or formoterol, and that you need to always use with a inhaled corticosteroid. And there's your combinations, like Seretide and Symbicort. Just maybe remember one or two to just throw in the OSCEs if you had to. And then there's other things you can consider as well, like leukotriene receptor antagonist, montelukast. That's more of a children's thing. Mast cell stabilizer and monoclonal antibodies as well. Yeah, and this is the step up. This is the from the new, I think, revised guidelines, but it's essentially what I went through, and just have a read of that. And then always assessing control of asthma. You want to know how good is their control, so you can assess whether they need to step up their management. And so from good control, you know, the daytime symptoms are like less than 2 days per week. It's not really impacting their daily function. You know, there's no symptoms during night as well, as opposed to poor control where they've got daytime symptoms. They need to use their SABA more than 2 days per week, and they have more frequent night symptoms. So next question, I might just leave you guys to read it. I'll give you a few seconds to do that. Okay, perfect, guys. So I'm getting exacerbation of asthma, COPD. So we're going to go over COPD now. Okay, so COPD is a chronic progressive obstruction airway condition that is not fully reversible. So traditionally, I think when I learned it last year, we said it was an irreversible obstructive airway condition. It's not technically true. It can sometimes show some reversibility, and that sometimes has to go to do with the fact that there's asthma and COPD overlap. We know that there are primarily two types, chronic bronchitis and emphysema. And we know that it occurs in 1 in 7 Australians over the age of 40, but we should consider it if it's in patients more than 35 years old. And as I mentioned, it's associated with asthma. The risk factors are smoking. Smoking is one of the main risk factors, but as well as a family history of alpha-1 antitrypsin deficiency, air pollution, post-inflammation, as well as chronic diseases, as I mentioned, asthma and chronic bronchitis. You can break down the pathology into sort of two categories based on the fact that it's either caused by chronic bronchitis or emphysema. So chronic bronchitis is like your airway inflammation, and your emphysema is like a tissue destruction. Now, I've got this picture. I know it looks complicated, but I think I'll try and explain it to you guys just to have a basic understanding of the pathophysiology and the pathogenesis. Okay, so hopefully I can do this clearly. So one of the major risk factors for emphysema is alpha antitrypsin deficiency and smoking. Now, if we start off with alpha antitrypsin deficiency, alpha antitrypsin normally breaks down elastase. Now, if you have a deficiency in that, it means we have this unopposed elastase. Now, elastase then breaks down elastin in the alveoli. Now, if we look at smoking, that causes a pro-inflammatory state. That also recruits the neutrophils that produce the elastase. It also causes an inflammatory state that causes destruction of the alveolar walls and the capillaries. As a result, you get alveolar collapse, which means that you get air trapping, but also because you're destroying the capillaries, you get impaired gas exchange. So this is a gas exchange problem. Emphysema is a gas exchange problem or diffusion problem. If we then address bronchitis, this is primarily due to smoking, and that causes, or a major risk factor is smoking. That causes inflammation, and this inflammatory state causes hyperplasia and hypertrophy of the goblet cells and the mucus glands, and that causes hypersecretion of the mucus. And you also get fibrosis and thickening because of the inflammation of the bronchial walls. And as a result, that results in a narrowing of the small airway. So this is a airway obstruction or airway obstruction, narrowing of the airway problem. So if we then go into, and I won't go over the pathophysiology again, but if we go into chronic bronchitis, this is our blue bloaters. So this is, it has a clinical definition of the presence of cough and sputum for at least 3 months in each 2 consecutive years. And as I mentioned, smoking is a really big risk factor for this. And I'll just go into more of the pathophysiology in terms of the complications. So as I mentioned, to recap, you get this airway obstruction due to the hypertrophy and hyperplasia of the mucus glands, as well as the fibrosis and thickening of the airways. As a result, you're not getting enough air in, so you get alveolar hypoventilation or hypoxia, and that leads to a VQ mismatch because you're getting reduced ventilation. Because you're getting a reduced oxygen in, you get hypoxia, but you're also not getting the carbon dioxide out, so you get hypercapnia. So because of the hypoxia, you get this compensatory increase in red blood cells, so you get polysthemia, but you also get the cyanosis. Now, because you're getting hypoventilation, the pulmonary vessels actually constrict to that area. And as a result, you get pulmonary hypertension, and that can lead to, therefore, cor pulmonale and the right heart failure signs as listed here. So you get like loud P2, these are cor pulmonale signs, so loud P2, parasternal heave, etc. So as a result, if we can link that to the symptoms now, they're getting chronic productive cough and sputum because of the mucus secretion. They don't get as much dyspnea compared to, say, emphysema, but still a sign to look out for. They're getting cyanosis because of the hypoxia and the hypercapnia. They get increased BMI as well. CO2 retention, so that's why you get the flapping tremor and the bounding pulse. And you also get crackles, wheeze, and also the cor pulmonale signs, as I mentioned. So as a result, you can understand now the complications are going to be pulmonary hypertension, cor pulmonale, and the resultant right heart failure, the polysthemia, and also the chronic hypoxia. So they get, as I mentioned, hypoxia and hypercapnia. That's a type 2 respiratory failure. And therefore, because they're getting the hypercapnia, they get respiratory acidosis. So not to forget, so no clubbing in COPD. In terms of emphysema, this is our pink puffer. So this has a pathological definition of permanent dilatation and destruction of the airways distal to the terminal bronchus. And as I mentioned, that's because of the elastase, increase in elastase, and you break down, therefore, the alveoli, and you get collapse and then air trapping and therefore hyperinflation. This therefore leads to a type 1 respiratory failure because of the hypoxia. So as I mentioned before, the risk factors are smoking, alpha antitrypsin deficiency is the main one, as like linked compared to bronchitis. And they tend to therefore get the dyspnea because the increased work of breathing. They get to more of a minimal cough, like not that as much sputum, and decreased exercise intolerance. And because they're working harder, they get the pink skin, the persistent breathing, they get cachexia, the tachypnea, the tripoding, the use of accessory muscle use, the hyperinflation and barrel chest, and then hyperresonant and decreased breath sounds. They also get a toast liver because they're becoming so hyperinflated, the diaphragm's moving down and it's pushing the liver down as well. And as a result, their complications are more to do with the increased work of breathing and the pulmonary cachexia, and they can also get spontaneous pneumothorax because of the bullae, they can rupture. So emphysema's also got 2 types, centriacinal or centrilobular. This has got to do with smoking, so that's a risk factor. And I always remember this as smoking sort of reaches the lungs first, so it affects the upper apices or the upper lobe. And this is destruction of the respiratory bronchus. So as you can see here, but it spares the distal alveoli. Whereas pan-asthma is associated with alpha-1 antitrypsin deficiency, and that affects the lower lobes, and it affects the entire acini or the alveoli. So I know that was a bit complicated, but back to basics. Chronic bronchitis is obstruction of the airway because of inflammation and all the mucus. And emphysema has got to do with gas exchange, and it's due to destruction of the alveoli and gas trapping. And here's just another contrast of those two. In terms of management, there's the COPDX guidelines by the Australian Lung foundation. And this is how they approach it. So they go case finding, they first look at the case findings and diagnosis, then optimizing function, preventing deterioration, developing a plan, and then managing any exacerbations. So we're going to go through this approach in terms of diagnosing and managing COPD. So just in general, as I mentioned before, COPD should be considered in patients more than 35 years with symptoms such as breathlessness, cough, and sputum, and in all smokers that are more than 35. You do your history and exam, as we've gone through, and we know that smoking is a very important risk factor. You then do your investigations. So again, you have to do spirometry to diagnose COPD, and they get an FEV1 ratio of less than 70 or 0.1. And that is an obstructive picture with a FEV1 less than 80% predicted. And I'll go over that. That's in terms of severity. Now, we know that when we do FEV1 and there's an increase in 12% and 200 mils, that indicates that there is some reversibility. You may see that with a COPD picture, and that might indicate either there's likely to be an asthma and COPD overlap. You might do some further investigations to exclude other conditions and ascertain the severity. So pulse oximetry, ECG, you might see that right sort of heart failure picture and strain picture because of the pulmonary hypertension and cor pulmonale. You'll then do your basic FBEs, CRP, UECs, LFTs, and then also your ABG. You can get respiratory acidosis, particularly if you're having the type 2 respiratory failure, so you're getting hypocapnia. And then your imaging, so your chest x-ray, and I'll go over that in a minute, and then you can do other long volumes, your echo, and you might do like an alpha 1 antitrypsin level if you thought it was indicated. So in terms of your COPD x-ray, you might be given a lateral x-ray, and that you need to look for a barrel chest, so that's increased AP diameter. You're looking for hyperinflation, so that's horizontal ribs, which you can see here. Widen space between the widen intercostal space, and you tend to see 10 posterior ribs. Flatten hemidiaphragm, hyperlicency, so you can see it's a bit more, I guess, air trapping. Decreased peripheral vascular lung markings, and also this narrowed heart or elongated heart. You then need to assess for the severity of COPD, and that's here. So this is like this is the FEV1 80% that we said before. You get less than 80% would be 60 to 80% would be mild, and so forth. But I won't go into this too much because I don't think you need to learn this off by heart at all. And then it's about optimizing function. So you need to suggest non-pharmacological things. So smoking cessation, pulmonary rehab, lifestyle changes, and then pharmacological things. So you start on your short-acting relievers. So that's your SABA or SAMA. So your short-acting muscarinic antagonist, ipratropium. Then it's a stepwise. So you add either LAMA, or a combination of LABA and LAMA. And then you add your inhaled corticosteroid. You can have this as a triple therapy. So your inhaled corticosteroid, say if you're on a LABA and a LAMA, you can add then the inhaled corticosteroid to that. And then I guess last line is a lung transplant. You then need to advise them on adherence and inhaler technique, manage any comorbidities because COPD can come with depression, anxiety, and other cardiovascular risks, and then referral to respiratory or palliative care if required. So this is a step up from the guidelines. I'll have a read of this if you prefer diagrams, and just, yeah, this is a really good summary. Then there's prevention deterioration. So again, encouraging smoking cessation, but immunizations, mucolytics to break down the mucus, and then long-term home oxygen therapy. This is only really indicated if they have a PaO2 less than 55, or they have it between 55 and 59 with cor pulmonale and pulmonary hypertension, etc. We aim for stats between 88 to 92% because of, remember, CO2 retainers. Because CO2 retainers, they become insensitive to carbon dioxide, and therefore they rely on their oxygen to drive their respiration. And if you give them too much oxygen, then they can actually cease breathing. And then you can develop a care plan, so GP management plan, COPD, and self-management community supports. In terms of managing exacerbations, so this is when they have any change in their baseline dyspnea or cough and sputum. One of the main triggers are viral, but also bacterial, and it's usually Haemophilus, Streptococcus pneumoniae, or Moraxella catarrhalis. And you need to ascertain on clinical features. Not only are you looking for a change in their shortness of breath or their cough or sputum level, but you need to ascertain, is this a bacterial cause? And there's sort of three things we go off to indicate that. So their sputum volume, any change in like this color of the sputum, and also do they have a fever? Because that's going to help with your management. So in terms of managing an exacerbation, you do like hospitalization, MDD, multidisciplinary care, etc. But you then do inhaled bronchodilators first, so salbutamol. Then you can add prednisolone, but then you do antibiotics only if it's suggestive of bacterial infection. So that's amoxicillin or doxy. And then you manage also if their oxygen is less than 92%, we give oxygen supplementation, and then you can escalate it to non-invasive ventilation if required. And then pulmonary rehab and discharge. So next question. So a 20-year-old man with a history of cystic fibrosis presents with a productive cough of yellow sputum and recurrent episodes of fever and tiredness. And on examination, you note finger clubbing and coarse crackles. And you guys are very quick. Yeah, perfect. Bronchiectasis, because we know that cystic fibrosis and bronchiectasis are very linked. And so I'm going to go through that right now. So bronchiectasis is a chronic lung condition resulting in reversible dilatation of bronchi, and it's due to inflammation, inflammatory destruction of the airways, and also because you get this persistently infected mucus. And there's sort of three ways you can break it down in terms of pathophysiology and causes. So it can either be due to like an infection and inflammation, or there's an obstructive cause, or there's impaired defenses. So it could be post-infectious, like pneumonia or TB. It could be that you have an obstructive cause, such as like a foreign body or COPD. And then impaired defenses is cystic fibrosis, so unable to clear that mucus and it becomes infected. In terms of one of the most common pathogens causing it, and particularly in cystic fibrosis and bronchiectasis, is Pseudomonas. So this is another cause of chronic productive cough. So your two main differentials for chronic productive cough is bronchiectasis and chronic bronchitis. And this can also be associated with hemoptysis, dyspnea, and then that recurrent infection and exacerbations. On examination, you can get clubbing. It's apparently not very common, but you can get clubbing and crackles as well, and a wheeze. In terms of investigations, you can do like your normal FBE, you can do a sputum culture, a spirometry, you can do a sweat chloride test if you thought it was cystic fibrosis, a bronchoscopy, a chest x-ray, but your gold standard is your high resolution CT. And I'll go over that in the next page, what you get on that. Management is like your chest physio, your antibiotics if they have an exacerbation, your smoking cessation, vaccines and surgery. So very similar to COPD. So on a chest x-ray, I don't know how clear you can actually see these, but you can get tram tracking signs. And that's just indicating the bronchial wall thickening because of that, all that inflammation and fibrosis, but it's not a very good indicator. You'll need to do a high resolution CT where you'll see the signet sign. So that's the dilation of the bronchi with the thickened walls here. And then you can also see the tram tracking a lot better on a CT, and that's the dilatation of the bronchi here. So next question. A 20-year-old male has a productive cough, wheeze, and steatorrhea. On examination, he's clubbed, cyanose, and has bilateral coarse crackles. His blood glucose level is measured at 11 millimole per litre. Yeah, fantastic. So this is cystic fibrosis, and there's a lot of things going on here. You've got your respiratory symptoms, but you also got your pancreatic insufficiency, and then also your diabetes induced by cystic fibrosis. And cystic fibrosis also is clubbed. It's one of the lung causes of clubbing. So we'll go over cystic fibrosis. Now, I understand this is an R3 for you guys, but they always love to add at least one question about cystic fibrosis. And you'll know more about this next year when you do your pediatric term. So this is a very brief overview. So as many of you know, it would be an autosomal recessive disorder due to the mutation in the cystic fibrosis transmembrane conductance regulatory gene on chromosome 7. This is accountable for 1 in 2,500 live births, and it's actually the second most common hereditary metabolic disorder. And main risk factors that you have a family history of cystic fibrosis and also carrier status. We know that it's mainly a mutation in the F508 mutation is the most common, but there's up to like 2,000 mutations. So essentially you have a mutation in this gene, and that encodes for a chloride channel. And because you have dysfunction in the chloride channel, the exocrine glands produce this hyperviscous mucus, and as you can imagine, that accumulates, it blocks ducts, and then that can lead to organ damage in various organs, whether it be lung, pancreas, intestines, reproductive ducts as well. So therefore, there's so many sort of complications and signs and symptoms you need to look out for, but I've kind of summarized the main ones that might come up on EMQ. So you get your respiratory, so that's going to be chronic productive cough and the recurrent infections and the bronchiectasis, as we mentioned before. But then you also get your pancreatic insufficiency, and that's because you're not releasing lipase, you get the steatorrhea. Because you're not getting absorption of fats, you get the deficiency in your fat-soluble vitamins, vitamin A, D, and K. And as you can imagine, vitamin D deficiency then leads to osteopenia and osteoporosis. And overall, you can get malabsorption. And we see this more in kids, but you get failure to thrive and growth failure. And then because it's damaging the pancreas, it also leads to diabetes, which, as we saw in the scenario. It can also lead to gallstones, as I mentioned, osteoporosis, osteopenia, and then also reproduction, because in men it blocks the vas deferens, and in women it can also lead to amenorrhea. In terms of examination, the main things that they might indicate on an exam question is bilateral coarse inspiratory crepitations, as well as clubbing, and HPOA as well as the hyperinflation and the hyperresonance and wheezing. So here's an overview of all the sort of manifestations of cystic fibrosis to give you a more global picture, but you don't need to know all of them, mainly just the growth failure, the bones, the pancreas, and the respiratory symptoms as well. Okay, next question. So 55-year-old female presents with a week-long history of cough, exertional dyspnea, rusty-coloured sputum, and her temperature is 38. Her chest is dull to percussion over the lung base posteriorly, and bronchial breath sounds are heard. So very buzzwordy. Yep, definitely community-acquired and pneumonia. Well done. So we're going to go over pneumonia now. Just checking the time. Okay, so pneumonia is an acute lower respiratory tract infection. So it's infection of the lung parenchyma. Now we can classify it as community-acquired pneumonia. So what that means is that this is pneumonia in people who are not hospitalized, or they've been hospitalized for less than 48 hours. If it's hospitalized acquired pneumonia, that develops in people who have been hospitalized for more than 48 hours, or they've just had a recent discharge. Ventilator-assisted pneumonia is when they have hospitalized acquired pneumonia, so it develops more, but it develops more than 48 hours after they've had endotracheal intubation. Now, in terms of the causes, I split it into community-acquired pneumonia causes, hospital-acquired, aspiration, and immunocompromised. So your community-acquired pneumonia causes are, we break it into typical and then atypical causes. So your typical is most commonly Streptococcus pneumoniae, Haemophilus influenzae, Staphylococcus aureus as well, and Moraxella catarrhalis is your main causes. Atypical, one of the main ones is Mycoplasma pneumoniae, as well as Legionella, and you may have heard these ones as well. There's also virus causes, so respiratory syncytial virus, adenovirus, and don't forget your coronavirus. And in terms of hospitalized acquired pneumonia, this tends to be due to MRSA, as well as your multi-drug resistant gram-negative bacteria. So that includes like Pseudomonas, Klebsiella, and E. coli. It can be due to viruses and Legionella, but it's less common. If it's going to be an aspirational pneumonia, it's just due to any anaerobes that are in the oropharynx. And if it's immunocompromised, you always have to think about fungal causes, such as Cryptococcus and PJP and Aspergillus. But it also, in immunocompromised people can also get it due to bacteria and viruses, as we mentioned, which are similar to like the community-acquired pneumonia. This is a path sort of thing you need to know, just very briefly. If it's in terms of types of pneumonia, we can have lobar pneumonia. So that's a consolidation of entire lobe. It's usually unilateral and it's usually caused by Streptococcus pneumoniae. If it's bronchopneumonia, that's an infection that affects the small bronchi and the bronchioles and the adjacent alveoli. So what you end up getting is this sort of patchy inflammation, as you can see here. And it typically involves like more than one lobe, as you can see here. But it's also typically bilateral as well. So it'll be like the two lower lobes. And that's usually due to Klebsiella, E. coli, and Staph aureus and Pseudomonas. Interstitial pneumonia means that it's causing inflammation of the interstitium, so the tissue around the alveoli. You also get a patchy inflammation for that, but it's quite diffuse. As you can see here, it's affecting like the entire lung. And that tends to be due to viral causes or mycoplasma. And I'll show an X-ray of this a bit later. You can also get miliary pneumonia, but that's due to like from hematogenous dissemination of TB. So don't worry about that one too much. Again, more pathology. I'm not going to go into this at all into detail, but just to mention that there are 4 stages of lobar pneumonia. So your congestion phase, that's 1 to 2 days. And this is when you're getting vascular congestion, edema. And then you have the red hepatization stage, and that's 3 to 4 days. And this is when you start to get the inflammation, the neutrophils, and it starts to look like liver tissue. And it's kind of red, sort of firm liver consistency. Then you get grey hepatization. So that's when you get 5 to 7 days. That's at 5 to 7 days, sorry. And that's when you get like fibrin deposition. It sort of becomes less blood and it becomes more grey looking. And then you start to get resolution. That's from 8 days. And then the inflammatory cells and the fibrin starts to break down and sort of the inflammation starts to resolve. But have a more look into the microscopic and macroscopic changes for path. In terms of risk factors for pneumonia, so this is when occurs in infants, but also in more than 65 years old. We know that pre-existing respiratory conditions can increase risk of pneumonia, immunocompromised, as we mentioned, and in alcoholism, we know that the buzzword for that is Klebsiella, pneumonia, and alcohol for some strange reason. And then also aspiration pneumonia. So you need to ask about, or at least look out for, is there an altered state of consciousness? Have they been, have a seizure? Is it post-op, and alcohol intoxication as well? These are sort of not really common at all, but there's more your buzzwords. So your water towers is your Legionella, your bird droppings is your chlamydia, and abattoirs is your Brunetti. If you do we had an OSCE on pneumonia last year, and so it's maybe good to ask about, have you been in contact with any birds? But other than that, you don't need to go into too much detail about that. Smoking, you need to ask about, hospitalization, sick contacts, and you need to ask if they've had their vaccinations, and a travel history. They're really important in terms of an OSCE approach. And then in terms of clinical features, you get the productive cough with maybe hemoptysis. But if it's mucopurulent sputum, it's typical bacteria. If it's watery sputum, it's your atypical bacterial virus. As we saw in the question, if it's rust-colored, it's your strep pneumonia, and the red currant jelly is your Klebsiella. Also get shortness of breath, pleuritic chest pain, systemic features. You need to ask about fever. They definitely have a fever. And then you can ask like chills, rigors, and diaphoresis as well. Sometimes if it presents atypically, you can get non-respiratory symptoms. But don't worry about that too much. And then in terms of, you need to know the examination findings for pneumonia. So vital signs, tachypneic, tachycardic, hypertensive, febrile, and look at their oxygen stats. On palpation, they'll have reduced expansion, they'll have a dull percussion note, and you're looking for bronchial breath sounds, inspiratory coarse crackles, and the vocal resonance will be increased. So know how to also listen for example, bronchial breath sounds. So you can practice that with audios. This is just a summary of the difference between typical and atypical pneumonia. Don't really need to know too much, apart from what I'm going to say is that atypical tends to be more constitutional symptoms, and they don't typically be they're not as ill appearing, I guess you could say. You may have heard of the walking pneumonia, which is due to mycoplasma, which is atypical pneumonia, and these patients are up and about walking around, and they're not as acutely ill. Yeah. So in terms of investigations, you need to do, an FBE for leukocytosis, CRP for inflammation, UECs. I think this is more associated, you can get AKA with Legionella, if I'm correct, but yeah, I guess also UECs you always do for, are they dehydrated? LFTs, ABGs for any respiratory distress, blood cultures if they're septic, and you look at a chest x-ray, and I'm going to go over the findings for that on the next page. There's a few other things you can do. You can do a sputum MCS, you can do nasal swabs for PCR, but if they're not really going to change a management, then they're probably not routinely done. Urinary antigen assay for Legionella, an IgM antibody serology for Mycoplasma pneumoniae, and all these other IgG as well. And you can do a bronchoalveolar lavage as well, but these are not routinely done. So in terms of how do you interpret this? So if it's a right middle lobe pneumonia, as I've got here, this is typical of lobal consolidation. So how do you describe this? So you sort of indicate that it's a hyperdense lesion or hyperdense, you can see hyperdense wedge-shaped consolidation in the right middle lobe. So you know that this is the right middle lobe because you've got loss of clarity of this right heart border. As opposed to right lower lobe pneumonia, again, you have this hyperdensity, but you have loss of clarity of the hemidiaphragm and the costophrenic angle. But you can actually see that the right heart border is clear, and that's how you distinguish between the two, or that's a key distinguishing factor. You can also see that you can get what's known as air bronchograms. They're a bit hard to tell, but you can see that there's these black lines, and they represent patent airways amongst the consolidation around the airways. And this is a infiltrative picture, so you can see this quite diffuse, patchy reticular nodular opacities, and this is more indicative of an atypical pneumonia. You don't really get the consolidation that you saw on the previous page. In terms of management, you always do doctors A, B, C, D, oxygen supplementation, IV fluids if required, but then you need to assess the severity of the pneumonia. So you need to assess, via Curb 65. That's the one that I sort of learned, but there's so many different tools. And that stands for confusion, urea, respiratory rate, blood pressure, more than systolic blood pressure less than 90, and diastolic blood pressure less than 60, and then the age 65. And based on this Curb 65, you then get a score, and that if it's like 0 to 1, that's mild. If it's 2, it's moderate, and if it's 3 to 5, it's severe, and you're considering admission. So based on the Curb 65 score, you consider, do they need to be admitted, or can they be treated as an outpatient? Then you can provide analgesia and then antibiotics. So the antibiotics that you can use depends on whether it's community acquired. So if it's community acquired, the empirical antibiotics goes by the mnemonic ABC. So if it's mild, amoxicillin or doxycycline. If it's moderate, it's benzylpenicillin and doxycycline. And if it's severe, it's ceftriaxone and azithromycin. Now, if it's hospital acquired, the empirical antibiotics goes by the mnemonic ACT. So Augmentin for mild, moderate is ceftriaxone, severe is Pip-Taz or Tazocin. Then there's some like other direct antibiotics you can use. Like once you get the sensitivities back, you can use these. So pneumococcal benzylpenicillin we know is really good for that. If it's methicillin sensitivity, it's Staph aureus, Flucox. If it's MRSA, Vanc, and if it's Legionella, azithromycin or Doxy and Kipro if it's severe. In terms of long-term prevention, smoking cessation, vaccinations are very important. And then in terms of complications, one of the main one is pleural infusion. but then that can progress to empyema, abscess, and septicemia. So now I'm going to move on to TB. So TB is an infectious disease caused by Mycobacterium tuberculosis, and it primarily affects the lungs. This is doesn't really occur commonly in Australia, but it can occur in the migrant populations, as well as in crowded living spaces, you know, in immunosuppression as well. We know that it is transmitted by aerosol droplets. In terms of the causes, it's Mycobacterium tuberculosis, and we know that this is an aerobic acid-fast bacilli. And so when we do the microscopic staining, it's with the Ziehl-Neelsen stain. You get with Ziehl-Neelsen. In terms of the pathophysiology, again, not going into too much about this, but you get, once you've inhaled the Mycobacterium tuberculosis, it causes a delayed T cell mediated reaction, and then that activates macrophages, and they can fuse to form what's known as multinucleated giant cells, and they basically have the engulfed TB. And then you get the granuloma formation. Now, granuloma is essentially, you have your central core, which has the macrophages with the TB, and then you have the outer core or the outer wall, which has the lymphocytes and the neutrophils. A GON focus is a caseating granuloma, and a GON complex is the GON focus with the lymph nodes. And that's a little bit of pathology there. In terms of classification of TB, so once the TB has been inhaled in the lung, there's four options. So it can either have immediate clearance, or you get primary disease. Now, primary disease can either be latent or active TB. And then you can have secondary disease, and that's also an active TB, but it's reactivated. So just to go over these a little bit, because I know this is something definitely confused me when I was in year 3. So latent is basically, you've had exposure to the Mycobacterium tuberculosis, and you get a cell-mediated response, and they're able to stop the bacilli from proliferating. So it's basically contained. So you still have some live TB in the granulomas, but you don't have the actual disease. It's not transmittable, they're asymptomatic. And the main test you do that for is the Mantone skin test and the interferon gamma release assay, which I'll go over in a bit. But this can reactivate. Now, if you have primary active disease, this only occurs in 5% of primary disease. So most of it's actually latent. But this is when you have failure of the cell-mediated immune response to actually contain the bacilli in the lung. And then that is transmissible and it's symptomatic. Reactivation or secondary disease occurs after an immunosuppressed state. Usually it becomes reactivated, and that usually tends to localize in the apical, the apical posterior segment of the upper lobes. And I'll show an example of a caveating lesion due to reactivation of the TB. And that is on X-ray, that is. And that is transmissible, it's contagious, and it's symptomatic. I just got a question, 1 minute. If there's again a person be reinfected, or do they have long-term immunity? Oh, good question. I guess they could be reinfected, especially if they had like an immunosuppressed state. But I would have to clarify that. If they had an immunosuppressed state, they could definitely be reinfected. In terms of latent, as I mentioned, there's asymptomatic. It tends to be asymptomatic or and not contagious. And if it's an active infection, as I mentioned, either primary or reactivated, it's contagious, and you get your pulmonary symptoms. So this is your productive cough, your hemoptysis, your shortness of breath and pleurisy, but it has to be for a 3-week period. And then you get constitutional symptoms as well. So your fever, your night sweats, your weight loss. Okay, in terms of now investigations, I'm going to break this down into what you do for latent TB and what you do if you have an active infection. So if it's latent, you want to test that there's been a cell-mediated immune response. So there's two main tests, the tuberculin skin test or the Mantos test. So this is when you actually inject the protein or the TB antigen under the skin, and then you look for a reaction 48 to 72 hours after. Two things about this, it's not very good at distinguishing between active and latent, and it's also can give a false positive if you've had the vaccine, the BCG vaccine. Second thing is the interferon gamma release assay, or the quantiferon TB Gold. So that measures the interferon gamma, as we know that's produced from the T cells in response to the TB to then like recruit the macrophages, etc. And this is not affected by the BCG vaccine. In terms of active infection, you do a chest X-ray, and if it's a primary active, you tend to look for higher lymphadenopathy and pleural effusion, and you can get the Gong complex as well. As we said, that's the caseating granulomas and the lymph nodes involvement. If it's reactivation though, like I mentioned before, in the upper lobes, you get these cavitating lesions. You may get the higher lymphadenopathy and the pleural effusion, but the main key feature is the caveating lesions in the upper lobes. You also do sputum samples, and you'll do microscopy on that for the Ziehl-Neelsen, which stain for the acid-fast bacilli, and then you can do cultures as well, but that takes about 6 weeks to grow. They can also do testing for rifampicin resistance via a NAT as well. So as I mentioned here, here's the workup summary that I've just gone through, but here's your caveating lesion in the right upper lobe because of reactivated TB. In terms of management, so for active TB, there's two things: infection control, so you do airborne precautions, N95 masks, negative pressure rooms, isolation, notification, and contact tracing. Then you do your treatment course. So this is by the mnemonic RIPE. So rifampicin, isoniazid, I'm not going to be able to pronounce this very well, but isoniazid and pyrazinamide and ethobutamol. So what you do initially is 2 months of the whole RIPE regime, and then you continue 4 months of rifampicin and isoniazid. If it's latent, you just do 6 to 9 months of isoniazid. Just a quick word on miliary TB, but don't really need to know too much about it, apart from saying that if you have lymphotogenous spread of the Mycobacterium tuberculosis, it then goes to various organs, so extrapulmonary involvement. But it still has pulmonary involvement, and you get like these millet seeds or white lesions. I'm not sure if you can see that, but just know that it's kind of widespread dissemination of the TB. Okay, next question. So this is a 17-year-old basketball player develops sudden severe right-sided chest pain and goes home early from school. He later presents to the emergency department with his mother and states his pain is worse with each breath and feels slightly short of breath. He is otherwise feeling well. Yep, all good. Yep, so this is definitely pneumothorax, very buzzwordy. We'll go through it now. Okay, so pneumothorax is a collection of air within the pleural space, and that's between the visceral and parietal pleura. So what we know is that you've got an air in this pleural space, and that actually increases the intrapleural pressure. And not to go back to our physiology of rest too much, but essentially what's happening is you're getting loss of that negative pressure, and we know negative pressure keeps the lung expanded. So if you lose that negative pressure, it's now collapsing. There's these different types, and I wouldn't worry about them too much, but there's a closed pneumothorax, and this is like when air enters through a hole in the lung particularly, and then if it's open, it's an air enters through the lesion in the chest wall. And then of course you've got your tension pneumothorax, and we need to know this one, so I'm going to go into that one in a little bit more detail in a minute. But just to generally go over the causes of a pneumothorax. So pneumothorax occurs either spontaneously, and that was in the example that we just went over in the question, and that's just idiopathically it occurs, but there are risk factors. So that's your young, slim male who's a basketballer, or they've got Marfan syndrome, or smoking as well. It can be secondary, like I mentioned, COPD, particularly emphysema. If those bullae rupture, that can cause a spontaneous pneumothorax, as well as asthma. and a few other lung pathologies. Another major one is traumatic, so either through blunt trauma or penetrating trauma, and then mechanical. So if you've had some like mechanical ventilation, or you've had a central vein catheter in, or you're taking a lung biopsy, you could easily puncture the lung. In terms of clinical features, so the main features is that they get this sudden onset of pleuritic chest pain and shortness of breath. When you're thinking about pleuritic chest pain, your main differentials, just as an OSCE aside, is pneumothorax, pericarditis, PE, and pneumonia. Okay, so you need to know the examination findings for pneumothorax and how this slightly differs from a tension pneumothorax. So if it's just a pneumothorax, no tension, the trachea is going to be midline. If there's a reduction, on palpation, there's going to be reduction on the lung expansion on that affected side, and you're going to get hyperresonance on percussion on the affected side. Your breath sounds are going to be reduced on the affected side, vocal transmission will be reduced, but you should also be looking out for a fractured rib, like have they fractured the rib and has this punctured the pleura? As well as if there's any sort of subcutaneous emphysema. You can do ABGs, assessing for respiratory function or distress, sorry, and then you can do a chest x-ray, which is actually gold standard, and CT chest if you needed more detail. Now, in terms of interpreting chest x-rays for pneumothorax, I don't think it's as clear on this one, but I've got a better one later when we go over tension pneumothorax, but I'm not sure if you can see my cursor, but here is a visceral pleural edge, and above that, there's no lung markings peripheral to that visceral edge. There's also sort of this radiolucency compared to the adjacent lung, which you can't really see, but you should also be looking for a rib fracture. And then also in this one, there's no mediastinal shift as opposed to what you would get if you had a tension pneumothorax. In terms of working up, so this is from ETG and I quite like it. You always consider doctor's ABCD, consider admission, any oxygen supplementation or analgesia required. If it's a small and clinically stable pneumothorax, you can send them home and review a chest x-ray in 2 weeks. If it's large and not clinically stable, you then need to put a small bore intercostal catheter and an underwater seal drain as well. If it's recurrent, you need to do pleurodesis, and this is basically where they can use medications, I think it's TOLG, and they actually adhere the lung to the chest wall to prevent any reoccurrences. Now let's go on to tension pneumothorax. So tension pneumothorax, as you may have heard, know or commonly referred to, is the one-way valve that affects the lung or the chest wall. So essentially what's happening is that during inspiration, the air enters the pleural spaces. But then during expiration, the air is actually unable to escape from the pleural space because it's a one-way valve. And as you keep taking in each breath, more and more air is drawn into the pleural space, and this increases this positive pressure within the chest. So you're getting this really high, I guess this high pressure environment, as you could say. And because of that, what happens is that you get the collapse of the ipsilateral lung because you're getting loss of that negative pressure, but you're also getting mechanical compression of the lung, so that leads to hypoxia, and then you're also getting compression of the heart. Now, if you're getting compression of the heart, that means that that it impairs the cardiac filling and therefore reducing your cardiac output. But you can also imagine that the pressure in the intrathoracic pressure is also increasing. And if we go back to cardiac physiology, that actually means that you get the gradient between the intra-abdominal pressure and intrathoracic pressure now is decreased. So you impair the venous return to the heart and therefore the cardiac output. So essentially, this is leading to hypoxia, but also hemodynamic instability because of the compression of the heart, and it actually leads to an obstructive shock. So this is a medical emergency. Again, the symptoms it's going to present similar to just a simple pneumothorax, sudden onset of pleuritic chest pain, shortness of breath, and then you consider your differentials again. But the examination findings are that now the trachea is going to be deviated away from the affected side. There's going to be, again, reduction of lung expansion on the affected side. You're going to get hyperresonance. You're going to be reduced breath sounds, reduced vocal transmission, but you also need to look for those respiratory distress signs. Are they hemodynamically unstable? And then also looking for fractured ribs as well, because that might be the underlying cause. So like I mentioned, tension pneumothorax is emergency. It's a clinical diagnosis. You don't wait for radiological diagnosis. You don't do a chest x-ray if it's going to delay your treatment. But in saying that, if you are going to do an x-ray, a chest x-ray, this is what you find. So it's similar to a pneumothorax in that you see the visceral pleural edge, absence of lung markings above that pleural edge, but you also see contralateral shift of the mediastinum now. You also get this depression ipsilaterally of the hemidiaphragm, and you can also see here there's actually widening of the intercostal spaces, but that's not so important. What's important is the mediastinal shift. And you can also do your ABGs in your CT chest. In terms of management, as I mentioned, medical emergency, doctor's ABCD, admission, supportive, so oxygen and analgesia, and then urgent decompression. So you need to do first what's called a needle decompression, followed by thoracotomy. So needle decompression is only temporary. What you do is you're inserting a needle at the second intercostal space, mid-clavicular line. I haven't got a picture here, but what that does is that actually allows for the air to escape and allows equilibrium between like the pleural space and the atmosphere, but it doesn't restore the negative pleural pressure. So then you need to put a chest tube in at the 4th and 5th intercostal mid-axillary line to then allow re-expansion and resealing. Now moving on to chest wall and rib fractures and flail chest. So a rib fracture is just a break in the rib bone, but if you have a flail chest, that's multiple rib fractures in 2 or more places. So now you're having what's a floating segment in the rib, essentially. The most common mechanism for this is a blunt trauma. And you can see this on a chest x-ray here. See multiple rib fractures here. They're going to present with pain, pain on inspiration, apologies, and shortness of breath. Now, this is a little bit small, but essentially to summarize this, on examination, you're going to get what's known as paradoxical movement. So the floating of the segment moves inwards during inspiration, but then also moves outwards during expiration. And that's and then the other findings would be if they had a concurrent, for example, pneumothorax, then you might see midline shifting on the trachea, you know, and you might percussion might be hyperresonant, etc. In terms of management, again, you don't really need to know this, but it's just oxygen, fluids, analgesia, and then treat any complications if they had like a pneumothorax or hemothorax and surgery. And as I mentioned, the complications, pneumothorax is probably one of the big ones you need to look out for. Okay, question. Might just give my throat a bit of a rest. So to summarize, unilateral chest expansion decrease, breath sounds decrease, and stony jaw percussion. Yep, perfect. Easy. So this is pleural effusion. So let's go over pleural effusion. Alrighty, running out of time a little bit. So I'm just going to quickly go over this. So pleural effusion is accumulation of fluid in the space. And hemothorax is blood. Chylo is chyle in the pleural space. And hemopneumothorax is blood and air, and empyema is pus. So this is your classification. So if it's less than, it's either transudative or exudative. Transudative is less than 30. Exudative is more than 30 grams per liter of protein. Transudative is bilateral, and exudative is unilateral effusion. And that's really important to know. Your light criteria, I'm not going to go over it, but sometimes you might get quizzed on the wards, and it's just in reference to effusion if it's exudative. So your transudative causes of pleural effusion are congestive heart failure, liver failure, nephrotic syndrome, or your failures. Exudative, you can categorize it as infection, malignancy, inflammatory, trauma, and surgery. So infection, pneumonia, malignancy, lung cancer, inflammatory, PE or rheumatoid, and trauma, such as hemothorax or pneumothorax. And this depends on the symptoms. It depends on the size of the effusion of the symptoms, but there tends to be like dyspnea, orthopnea, cough. And for this, like we said in the question, it's going to be decreased. You can get deviation if it's of the trachea if it's large, but it's decreased expansion, stony dale, decreased breath sounds. In terms of investigations, the main thing is that you're doing a chest X-ray, and you can see here that you get this, it's what's called as homogeneous opacification with the meniscal sign, concave meniscus sign. And if it's unilateral, that's exudative. If it's bilateral, it's transudative. You can also do a pleural tap, and you send off the, take the fluid, pleural fluid, and you send it off for analysis. And that's showing that there. And this is what you get on analysis. You do not, by no means do you need to know this, but you look for the appearance, the biochemistry, the cell count, the cytology, and MCS for organisms. In terms of treatment, the main thing is that you just do a pleural tap. And then you might do, if it's like viscous, this is more for empyema, but you'll actually do, you'll use what's known as intrapleural enzyme therapy, and that can break down the pus. You can do a pleurodesis as well and surgery, but essentially pleural tap is the main treatment. Let's move on to empyema. So empyema is accumulation of pus in the pleural space. It's usually secondary to an infection such as pneumonia. And with this, you get shortness of breath, cough, and sputum, but it tends to be foul-smelling sputum. You get pleuritic chest pain, fevers, because you can imagine now this is like superimposed with the infection, and your Raynaud's chills, etc. In terms of vital signs, examinations, you look out for sepsis signs. Examination, again, reduced expansion on the affected side. It's going to be delta percuss, breath sounds are going to be reduced. You can do all your investigations, and I guess to rule out other things as well. You'll do a chest X-ray, and it looks very similar to a pleural fusion. And then again, you'll be doing that pleural tap and sending off the pleural fluid for analysis, because it's going to be quite purulent when you look at it. You might have a gram stain and culture positive because it's due to a secondary infection. And you get also like low glucose and increased LDH, and the pH is like less than 7.2. But you don't need to know too much about it, but just know that, you know, you can send off for analysis. In terms of treatment, very similar. You do pleural drainage. And then if it's got an infection, you'll do also empirical antibiotics. And then you can also give the intrapleural enzymes, as I was mentioning, to break down the viscosity of that pus, and then surgery if required. I might just move on to the next thing, just because I think I'm running a bit out of time, and I'll let you guys do that one in your own time. But I know this isn't actually part on the rest matrix, but I thought PE is probably one of the main common respiratory conditions that you need to know. So I just want to cover it, and I apologize if this overlapped with the HEME lectures yesterday. But just to quickly go over it, as you know, PE, you get obstruction of the pulmonary arteries. It can either be a solid, it can be liquid, it can be gas. But essentially what happens is you have a thrombus in the distal veins, it then embolizes and it lodges in the pulmonary arteries, and as a result, you get right heart failure. We know that our saddle emboli is the one that kind of like gets stuck in the junction of the pulmonary artery. And we know that it can either, like I mentioned, it can be DVT, but it can also be fat emboli that can get, that can travel to the lungs. It can be air, it can be amniotic fluid, tissue, etc. I'm not going to go over the risk factors, but remember your Virchow's triad, hypercoagulable state, circulatory stasis, and vascular wall injury. In terms of classifying a PE, it can be provoked. That means it's associated with these risk factors, or it can be unprovoked. So you've not had any risk factors for 3 months leading up before it. In terms of your clinical features, it's chest pain, shortness of breath, cough and hemoptysis, syncope, palpitations, unilateral swelling of the legs, diaphoresis, and this feeling of impending doom. And then don't worry too much about what you get on, I'll let you read what you can get on examination. I'll just quickly go over the workup. So basically what you want, first thing you do is, if you suspect someone has a PE based on their symptoms, and you do what's known as the Wells criteria, and this goes to see how likely is a PE. So if it's more than 4, you then do a CTPA. and you confirm it. If it's less than 4, you then do D-dimer. And if the D-dimer comes back as 500, more than 500, you then proceed to a CTPA. But if it comes back then less than 500, then it rules it out. It's really good. It's highly sensitive, but not specific. So it can be due to, like, you can have raised D-dimer, which is a breakdown product of fibrin due to malignancy, infection, etc. It's good at ruling out things, but not ruling in. And then, as you know, you can do your do you have to know the Wells criteria? No, I don't think you do need to know it off by heart. At least I don't think I remembered it off by heart. But just get a general sense of what it sort of includes. But no, you do not probably need to know it off by heart, or at least I hope you don't. And in terms of other bedsides, you do your ECG and then all your bloods. Make sure you do beta HCG, because when you do a CTPA, there's 3 reasons why you can't do a CTPA. They're pregnant, they're allergic to contrast, or they have renal failure. And I'm so sorry that I'm rushing over this, but I know this was covered yesterday, so I might just move on. And this is the management. So doctors A, B, C, D, and you basically start them on anticoagulants. If it's large, you do a thrombolysis, so break down the clot, or you can do surgical embolectomy and then continue them on anticoagulants and review after 3 months. And these are the complications. Recurrence can happen, pulmonary infarct, they can get pneumonia as well. I'm running out of time. I'll just quickly summarize this. So OSA basically is when you have either complete or partial upper airway obstruction. Key things you need to know is that it occurs in males and typically associated with obesity. They kind of wake up, have this restless sleep where they have episodes of either snoring, so partial obstruction, or they have apneic episodes and actually stop breathing. And they can have this daytime sleepiness. You do sleep studies and an EEG, and basically they look on the EEG, and basically on that they can diagnose it. And there's a few other things that you'll do in terms of investigation, ruling out any comorbidities. In terms of management, it's SNAP-W, but the first line is CPAP. That's probably take-home message, CPAP. It keeps the airway open. Sorry, I'm rushing over that, but I want to get on to this. So in terms of lung cancer, there's differentials for lung masses and either benign or malignant. So this is just a general approach. So either for benign, they can be infectious, so tuberculosis, fungi, etc. Inflammatory, it can be sarcoid, and then and a few other things like hamartoma, the popcorn calcification, another buzzword. Or it can be malignant, and we're going to be talking about your primary lung cancers, but also don't forget metastases. So an overview. So lung cancer, malignant proliferation of the parenchyma, and tracheobronchial tree. Main risk factors are smoking, occupational exposure. There's two types here. So we break it down into small cell lung cancer and non-small cell lung cancer. And non-small lung cancer then breaks into adenocarcinoma, squamous cell carcinoma, and large cell carcinoma. In terms of small cell lung cancer, this is your small central perihilar tumor with large nodal mets. And it's basically, I'm just going to go through a few important points here. Paraneoplastic syndromes. So Cushing syndrome, SIADH, Lambert-Eaton. And these are quite aggressive. They sort of always spread. So therefore we treat them with chemo and radio because they're not good candidates for surgery if they're disseminated. For non-small lung cancer, it's adenocarcinoma. This is most common, and it's in your women, most common in women, but not in it's in non-smokers. This is your peripheral lesion and single lesion. And in terms of squamous cell carcinoma, they're more large central perihilar, with small mediastinal lymph nodes. And this is also associated with paraneoplastic, but it's with the hypocalcemia or increased parathyroid. This is a strong link with smoking. And then you have your large cell carcinoma, and this is peripheral. They're really poorly differentiated, and probably don't need to know too much about this apart from like maybe identifying it on a pathology, histology, and this can also be treated with surgery if localized. So one point I want to say is small cell carcinoma is very disseminated and aggressive. Adenocarcinoma, it's more local, it might spread to lymph nodes and disseminate. And then squamous cell carcinoma is very localized. And local is like lung parenchyma, bronchus. It can then spread to the lymphatics, peribronchial, mediastinal, and then hematogenous spread is to your lung, liver, bone, brain, and adrenal glands. And transcholemic is like you get your pleural effusion, so your malignant pleural effusion. And then you get your typical signs of cough, hemoptysis, dyspnea, chest pain, wheezing, and then don't forget to ask your constitutional symptoms, because that's going to be a really big clue in an OSCE, is this lung cancer? And then you can also ask about symptoms of where they've spread. So you can ask about like bone pain, if they've spread to the liver, like you can ask about jaundice and ascites, or if it's spread to the brain, you can ask about like your headaches and seizures. In terms of other features, we know that, I'm just going to go over this point. So we know that non-small cell lung cancer is associated with pancreas tumor, and then your squamous cell carcinoma is your paraneoplastic syndrome with high increased parathyroid, and then your small cell carcinoma is your paraneoplastic, but it's SIDH, Cushing, and Lambert-Eaton, as I mentioned. And always also ask about your compressive symptoms. So hoarseness of voice because it's compressing the laryngeal nerve, or dyspnea because it's actually compressing the phrenic nerve, so that can also lead to dyspnea. In terms of your workup, so you can do like FBEs, liver, like LFTs for liver mets, UECs and CMP for paraneoplastic syndrome, so like hypercalcemia. There's a few things that you can do. So like, chest x-ray is going to see like, is there a primary tumor, and you see like this spiculated lesion. CT thorax abdo is more like for staging and like seeing if it's disseminated, as well as your PET scan, your bone scan as well. You can do a bronchoscopy and take a biopsy. And you can also do a CT guided biopsy and put that under histopath. You can do an FNA biopsy. I'm not sure. Yeah, you can do an FNA biopsy, but that's only going to be looking at the cells for cytology. And then you can do a pleural tap as well, but again, you'll only be looking at the cells. You can also do sputum. And so in terms of treatment, so you don't need to know too much about treatment for lung cancer, but you can break it down very simply. So for management, there's your surgical options, so a lobectomy or pneumonectomy, and I've got pictures on the other side, on the other slide, and small wedge excision. You can also do chemotherapy or radiotherapy, but as I mentioned, that's going to be if it's localized and not disseminated. And then you can do targeted therapy. So EGFR inhibitors, and I didn't mention this because I apologize, I'm going super quick, but adenocarcinomas have the EGFR mutation, so therefore you could use an EGFR inhibitor. You can also use immunotherapy, and then as well as considering pain relief and any sort of psychotherapy and antidepressants that also as comorbidities. And that's a picture of like a wedge resection, lobectomy, pneumectomy as well. Again, I'll let you do this in your own time. Sorry, guys. So interstitial lung disease. Basically, this is just a heterogeneous group of disorders that affect the interstitium. And basically what you get is inflammation and irreversible thickening of the interstitium and the alveoli, and that impairs gas exchange. So this is a gas exchange problem. There are so many causes of ILD, and but the main one that you need to know is idiopathic pulmonary fibrosis. But if you go through these, like drugs, for example, methotrexate and amiodarone cause lung fibrosis, infectious causes, autoimmune, like like sclerosis, sarcoidosis, and then also your occupational. So this was something that I sort of learned last year. For interstitial lung disease, they can either be upper lobe or lower lobe predominance. For upper lobe, it's by this mnemonic, so silicosis, Cole, workers pneumoconiosis, hypersensitivity pneumonitis, angst-spond, radiation and TB. And then for lower lobe, it's rasio, so rheumatoid arthritis, asbestosis, sclerosis, idiopathic pulmonary fibrosis, and other drugs. So now going over idiopathic pulmonary fibrosis. So this is basically So this, sorry, I was just reading chats. This is basically when you get, again, irreversible fibrosis and scarring. And this is a restrictive lung disease. And the risk factors, we don't know what it's caused by, but there's going to be risk factors. And as you can imagine, cigarette smoking is a big risk factor. They present with 3 things I'm going to go over. So cough, clubbing, and crackles. That's like your 3 buzzwords that you'll get on a EMQ, but also dyspnea. And the crackles are fine inspiratory crackles. Should have mentioned that. Then you'll do your spirometry. It's going to be a restrictive pattern. And the next thing that you'll do is a high resolution CT. Don't worry about management too much. It's very complicated, but you can have a read of that in your own time. So on the high resolution CT, you get this honeycombing. And on the chest X-ray, if you do one, you get this very reticular nodular pattern. Sorry guys, I'm going to have to skip this. But sarcoidosis in one, literally you guys do not need to know much about this. Apart from that, it's a multi-system disorder and you get non-caseating granulomatous inflammation. You then need to understand that there's pulmonary symptoms. So you get like dry cough and dyspnea, and it can go to the lymph nodes and it can cause uveitis, and you get skin manifestations as erythema nodosum. You may also see on your exam questions that there's increased ACE, and that there's also on biopsy that there is non-caseating granulomas, as I mentioned. Quickly, I think I have like 9 minutes, so I'm just quickly going to go over any other lung pathologies. This is more like pathology related, but you get like occupational lung disease, and I cannot pronounce this word, but pneumoconiosis, I think I did that fine, which you break down into coal worker pneumoconiosis, silicosis, and asbestosis. And then your extrinsic allergic alveolitis, and then your neoplasms, as we went over lung carcinoma. Please refer back to the slides. I know I rushed over it. And then mesothelioma. So pneumoconiosis is basically lung diseases due to any inorganic dust. So whether that be coal, silica, or asbestosis. Coal worker pneumoconiosis can be broken down into kind of 3 categories. So anthracosis is more mild and is not as much like small amount exposure to coal dust. And so this is like buzzwords like your city dweller or your smoker or coal miner. And you tend to get like this big black carbon pigment on the lung parenchyma, but not so much fibrosis at this stage. Then you can get simple coal workers. So again, they're the coal workers, not as much city dwellers. And as I mentioned I'm going through the upper and low predominant coal worker pneumoconiosis is more of an upper low predominance. And you start to get some fibrosis here. And then it can be complicated with coal worker pneumoconic, you know what I mean. And this is due to, now you're getting like this dense fibrosis and carbon deposition. Silicosis, due to silica, and your buzzword there is sandblaster or minor or heavy exposure, but mainly sandblaster. And again, that is due to, it's in the upper lobe again. And you get like, these pale sort of nodules on histology or macroscopic histology. Last one here is asbestosis. It's usually due to heavy exposure, like over 10 years. This is lower lobe predominance, and again, a cause of your interstitial fibrosis. You tend to get this pearl stains with like ferruginous asbestosis fiber, and they typically stain like dark blue. And these are some of the complications, like as I mentioned, fibrosis, pleural plaques, pleural fusion, and mesothelioma. Just quickly going over your hypersensitivity pneumonitis. So this is due to organic particles, and that causes an inflammation and therefore pneumonitis. One of the main causes like farmer's lung or bird's fancier lung. In terms of mesothelioma, this is a tumor of the pleura, tumor of the pleura or the mesothelium that lines the pleura, and it's linked with asbestosis exposure, and you get like these nodules and thickening of the pleural space, and that like entraps the lung, so making it quite restrictive. And some of the things that you can do for this is, you can do a CT scan and you'll see the nodular thickening, but you can also do a pleural tap and cytology to look for like the mesothelium cells. And essentially to treat mesothelium, you need to like pleural decortication or getting rid of the pleura. Okay, quickly some OSCE tips. So basically, it's important when you're approaching OSCEs, you don't have to like have 500 differentials. Essentially, identify your red flags, because that's what they want to make. They want to see, can you identify what is really important, what's life-threatening and severe and needs to be urgently treated, and 2 common differentials, at least about 2 common differentials. Know your system review questions and your cluster questions, but also know them according to differential topics. So therefore, some of the main common ones are shortness of breath, chest pain, and knowing the difference between pleuritic chest pain and ischemic chest pain. Because that way you can automatically know, okay, is this going to be a resp cause or a cardiac cause? Cough and sputum, cough and hemoptysis. Know how to distinguish between vesicular breath sounds and bronchial breath sounds. I remember before the OSCEs, I was just like listening to the differences on audio files, and know wheeze and also crackles on audio. And then also know how to interpret spirometry, flow volume loops. It's a bit mean, but they might chuck that at you. And chest x-ray and ABGs as well. And then also know how to explain your conditions in simple language. So, explaining what asthma is, COPD, because if you had to explain it to a patient, then, you'd have a really good way and patient-centered way of doing it. And also explaining the use of asthma, dose inhalers, and your asthma management plan. And that's about it. These are some buzzwords that I've put in for you guys. And good luck, everyone. You all do awesome. I know this year's been crazy, but I'm sure you'll all do fine. And hope to see you guys next year on the wards. Hopefully everything's back to normal. Good luck with everything, guys.
Thank you so much, Anthea. That was a really wonderful presentation, and sorry, a bit short on time. There's always a bit too much content to cover. We have a few minutes to spare, so if anyone has any questions, otherwise we might just break for about 5 minutes. Everyone can have a quick refresh, and then we can get back in 5 to start on some high yield neuro with Yingtong.